Today we are going to discuss about a specific type of Mendelian pattern of inheritance, which is X-linked inheritance. And this is a unique pattern of inheritance which arises because of the differences in sex chromosomes between the males and females. So as you're all aware, and we can see over here, the males and females share 22 pair of autosomes, which are exactly identical between the two genders. However, the sex chromosomes which actually determine the gender of the individuals are different between the males and the females. So the male have one X chromosome and a Y chromosome, and the females have two X chromosomes and no Y chromosome. So as we can see also by the karyotype, the X chromosome is much bigger as compared to the Y chromosome. So in fact, it's around 3 times bigger as compared to the Y, and it's also a very gene-rich chromosome. So there are believed to be around 900 to 1400 genes on the X chromosomes, whereas the Y chromosomes has around 70 to 200 genes. So a female would be having these many number of extra genes as compared to the male, just because she has two X chromosomes. So, but this kind of dosage imbalance in the genes actually gets corrected because there is a phenomena called as lyonization or X chromosome inactivation, which occurs in all females. And this is a process whereby only one of the X chromosome remains active and the other X chromosomes becomes inactive. So in every cell of a female, out of the two X chromosome, only one X chromosome will be functioning. But this process of inactivation of one X chromosome is a completely random process. So it is possible, and that's what usually happens, that in one cell, one of the X chromosome will be functional, whereas in the other cell, the other copy of the X chromosome will be functional. So different cells have different copies of the X chromosome being active and the other copy being inactive. And by virtue of this process, finally, the dosage of the genes on X chromosome remains same between the males and the female, and this corrects the dosage imbalance. But then this is something which also we can extrapolate and say that due to this kind of random X inactivation, in fact, all females are actually mosaics. So they are mosaics for their X chromosome copies. So some cells have a different X chromosome genes functional, and the other cells have the other X chromosome gene functional. So this in fact can also be observed in some females who are carriers of some X-linked recessive condition. So for example, here are this is what is shown is actually the muscle biopsy staining for the dystrophin gene in a patient who is carrier of dystrophinopathy or Duchenne muscular dystrophy. So whereby there would be a deficiency of the dystrophin protein in the muscles. So here you can make out that some of the muscle bundles here you can see are very faintly staining. So here basically these are the cells which are having that particular X chromosome active where the DMD gene mutation is present. So these cells are not expressing any dystrophin protein, and that's why the very faint staining can be seen over here, whereas there are many cells whereby you are seeing expression of the dystrophin protein, because in these cells the X chromosome copy which has the normal dystrophin gene or the DMG gene is functional. So these cells are all expressing dystrophin normally. So you see a kind of a mosaic pattern of the cells when you do such special staining for dystrophin. And similarly here you can see a lady who is carrier of X-linked hypohidrotic ectodermal dysplasia, which causes deficiency of sweat glands, and these sweat glands are kind of distributed along dermatomes. So there are some cells which are able to express the particular protein which is ectrodysplasin, and wherever the cells which along a particular dermatome which are expressing the protein, because in those cells you have that copy of the X chromosome active which has the normal allele of that particular gene. So those will all stain positive with iodine because they are secreting sweat. and whereas the areas there are some streaks, or those are the dermatomes where the cells are actually having that X chromosome expressed where that particular gene is mutated. So those cells are not making any not able to those areas are not having any sweat glands, so you get this kind of streaky pattern of sweat production on these women who are carriers for that particular mutation. So this is just kind of a demonstration of the process of how there is mosaicism happening because of the inactivation, the random inactivation of one X chromosome. So now let's move on to the inheritance pattern per se, so which is the X-linked inheritance. So basically diseases which are known, which are said to have X-linked inheritance, are conditions or diseases determined by genes on the X chromosome. And here because of the difference in the sex chromosomes between the males and females, there would be a unique pattern of manifestations in males and females, and you would see certain kind of inheritance kind of patterns, or some specific features when you look at a large family where this kind of condition is getting transmitted. So one of a classical X-linked condition is hemophilia A, which is caused by mutations in the F8 chromosome, F8 gene, sorry, and this is the gene. This gene is located on the X chromosome. So there is no copy of this gene on the Y chromosome. So here we have a lady who is having now two X chromosomes. One of them has a normal copy of the F8 gene, which is blue in color, and the other copy is mutated, that's denoted in red. And this is her partner, and he has a normal copy of a F8 gene. He's completely healthy, and the Y chromosome does not have any copy of this gene. And since this particular condition actually it shows an X-linked recessive inheritance. So basically what that means is that just one copy of the gene being mutated does not lead to any disease manifestations, because there is another healthy gene which is there, and this kind of masks the effect of the mutated gene. So therefore, the lady who is now what we call as heterozygous for this mutation or carrier, so this lady will be clinically asymptomatic, and even her partner, of course, is asymptomatic. And then once during gametogenesis, then these chromosomes or these F8 gene copies are going to segregate in different ways. So this lady can pass on her X chromosome with the mutation, and if she passes it on to a girl child, this girl child is going to get another X chromosome from her father, and this X chromosome then again is going to take care of the mutated copy. So there is not going to be any phenotypic consequences, and she will also be a asymptomatic carrier just like her mother. And however, if this lady passes on this mutation to her male child, then this male child, there is not going to be another protective X chromosome. The other sex chromosome he gets is the Y chromosome from the father, which does not have the F8 gene. So this boy does not have now any normal copy of the F8 gene, and he is going to manifest this condition or be affected with hemophilia A. And such individuals or such males are called as hemizygous for the particular mutation. And then, of course, the other two possible gametes which can come from this lady would be the ones carrying the normal X chromosome. So if it's a girl, then this girl would get the other X chromosome from her father, which would also have a normal F8 gene. So she would be completely healthy and not even a carrier. And similarly, the boy also does not get any mutation in the F8 gene and is also going to be healthy. So there are four kind of children which can be conceived from this couple, whereby the lady is carrier of an X-linked recessive condition. So around one affected male child can be there. So out of two possible male children, so there is a 50% chance of male offsprings being affected with this condition, and 50% chance of female offsprings being carrier of this particular condition. So if we see the segregation happening for a person who is affected with hemophilia A, so this would typically be a male who would be having a mutation on the X chromosome, the F8 gene, and he would be having other chromosome as the Y chromosome. So, and we assume that his partner is healthy and she has two copies of the normal F8 gene. So now this particular couple also, there are four type of offsprings which can be conceived. So we could have the father passing on his X chromosomes to his girls. So always he would be all his girls are going to get his X chromosome, and these girls would get the one normal X chromosome from the mother. So all his girl children are actually going to be carriers for this condition, and because he cannot pass on his X chromosome to his boys. So these boys will always get a Y chromosome from him, and they're going to get a normal X from the mother. So all his male children are going to be healthy. So basically, we are going to have all female children of an affected person being carriers of that particular condition, and all the male children being completely healthy. So let's just look at this particular family here. So here we have one person who is affected with hemophilia A. We do not have any family history here. So in such a situation, there are various possibilities. So one possibility is that this person could have got the mutation from his asymptomatic mother, who could be a carrier, but because it's an X-linked recessive condition, so she is not manifesting. So this could be one scenario, and there could also be the possibility that his mother is not a carrier, and he developed a de novo mutation in the F8 gene during the process of gametogenesis. So if we now see eh, further and we try to look at subsequent generation of this family, we find now that his sister also has a child who is affected with hemophilia A. So now in this situation where we are already having two affected males in the family, and the common connecting point is of course his sister, so we know that this lady would be an obligate carrier of hemophilia A. So she is heterozygous for the mutation, and she's passed it on to her male child, and her brother is hemizygous for the mutation, and that's why he's affected. And in most likelihood, in such a scenario, the mother of these two individuals is most likely a carrier. So she is also heterozygous for the mutation, and she passed it on to her this daughter and to this son who is now affected. So this kind of transmission, which is kind of passing in an oblique fashion, is known as oblique transmission, or also known as a Knight's move transmission. And basically what we are seeing is affected males in the family who are connected through asymptomatic unaffected females. And now when this person marries and reproduces, then his daughter always would be an obligate carrier, because he's always going on to pass on his X chromosome with the mutation to all his daughters. So these are some of the characteristics of X-linked recessive inheritance. So typically the males are affected and they are called as hemizygous for the mutations. The females are not affected with X-linked recessive condition. You would never see a male to male transmission, because a male cannot pass the X chromosome to his boys. This would never be seen. In fact, whenever if you see male to male transmission, then that particular condition cannot be an X-linked condition. And then if there is a carrier female for such conditions, then 50% of her sons are likely to be affected, and 50% of her daughters would be carriers. And for an affected male, all the daughters would be carriers and all sons would be normal. Affected males or family are connected through carrier females, and an affected child would have an affected maternal uncle, provided it's a familial transmitted mutation. So you would see something called as an oblique or a Knight's move transmission. So some common X-linked recessive diseases are as follows. So one is hemophilia A, as we just discussed. Then there is hemophilia B, factor 9 deficiency. Then you have another common neuromuscular condition called as Duchenne muscular dystrophy. Then certain metabolic disorders like Hunter disease, Menkes disease, Lowe syndrome, some types of Lissencephaly. So these are all conditions which are inherited in an X-linked recessive fashion. And there are also many X-linked intellectual disability syndromes, many of which show a recessive kind of inheritance pattern. So, how do we counsel a family where we are suspecting X-linked recessive condition? So, for an affected male, the risk to the siblings of this person is going to basically depend on the carrier status of his mother. So, if the mother is carrier, then there is a 50% chance of his male sibs being affected and 50% chance of his female sibs being carrier. If the mother is not a carrier, in such case, the risk to the siblings is low, but it is not zero because there is also possibility of a phenomena called as gonadal mosaicism, whereby the mother may not have the mutation in her blood cells, but she may be having a mutation in her gonads or in her germline. So in her gonadal cells. So, in such a situation, she could have more than one child affected with the same condition, although her blood cells are not showing the mutation. And then, for an affected male, no offsprings would be affected because his male children will anyway not be affected, and female children would be asymptomatic carriers. And this is how you would be counseling a family. So here let's just look at one particular interesting case, a family who had come to us, and this is the lady who had actually consulted us, and she was pregnant, and she was concerned that there are multiple people on her mother's side who are affected with a neuromuscular disorder, and all these individuals had died in their teens. So the history was basically that they had onset of neuromuscular weakness in early childhood, and they had become bedridden at around 12 to 14 years of age, and subsequently all of them had expired in late teens. So no genetic evaluation had been done for these individuals and no testing had been performed. But if we just look at this pedigree, so just by looking at it, we can immediately make out that this looks like an X-linked recessive inheritance pattern. We have only males affected, and all these males are connected through asymptomatic females in the family. So this certainly looks to be an X-linked recessive condition. And we know that there is a common neuromuscular disorder which is inherited in an X-linked recessive pattern and which has this kind of classical clinical manifestation. So that is Duchenne muscular dystrophy. So by looking at the pedigree and by ascertaining the clinical manifestations, we were able to think that this probably is a family whereby there is segregation of Duchenne muscular dystrophy happening. And then after doing this now, what we can do is that we can try and identify the females who are likely to be obligate carriers. So obligate carrier basically means that that individual is surely a carrier of that disease. And how we find such individuals are that basically they are connected to two male affected individuals. So if we see this lady, she has a brother with that particular condition, suspected DMD, and her own grandson, two grandsons are also affected with the same condition. So she is an obligate carrier of this condition, and also her daughter, because her daughter's uncle and her daughter's sons are also affected with the same condition. So these two are the obligate carriers in the family. And once we know that she is an obligate carrier, so there's a 50% chance that her daughter, that is the consultant's mother, would also have inherited the same mutation. So and then there is a 50 subsequent, if she has inherited, then there is another 50% chance that this lady could also be a carrier. So here in such a family, the ideal thing is to test the affected persons, but of course here they are not alive. So the next ideal thing is to test the obligate carriers, but unfortunately these people were not available. So we did the testing to look at carrier status for the consultant's mother, and in fact we were able to find that she indeed had heterozygous deletion involving multiple exons of the DMD gene. So this lady, that is the consultant's mother, was a carrier of exon 46 to exon 55 deletion, and the name of this test or the technique is MLPA. So once we know that this lady is a carrier now, so now there is a 50% chance that this lady also could be a carrier. So next we did testing for her, but luckily she did not inherited the from her mother. So now we know that she is not carrier of the familial mutation, so there is no risk to her baby being affected with DMD. So accordingly, we were able to counsel this lady. So the point here to note is that basically, if we make a proper pedigree, you can recognize the inheritance pattern, and this kind of inheritance pattern, which is a classical obliques transmission whereby multiple males are affected, females, asymptomatic females are the carriers. So this kind of um, uh, making a proper pedigree actually helps us in identifying the carriers in the family, and then we can perform subsequent testing and offer them reproductive options. So let's now move on to another type of X-linked inheritance, whereby you can have manifestations in females. So basically here now we are talking about conditions which are dominant, so which manifest even with a heterozygous mutation. So one such condition is X-linked hypophosphatemic rickets. So here we have a lady who is affected with this condition. So this is basically an X-linked dominant condition. So this lady is heterozygous for a mutation in the PHEX gene, and she has one normal X and and the other one with the mutation on this gene. And her partner has a normal X and a Y chromosome. So in such a case, again, during segregation, this lady will transmit this X chromosome to 50% of her offspring. So if that offspring is a female, then that child will also be affected because this is a dominant condition. And if that offspring is a male, then that child is also going to be affected. And usually in such a situation, because he doesn't have a protective normal X chromosome copy, he's going to be more severely affected. And then, of course, 50% of her children would get her normal X chromosome. So these would be unaffected. So this is X-linked dominant inheritance. So similarly, if a male is affected, so again, in such cases, all of his daughters are going to be affected because they are going to get his X chromosome with the mutation, and all of his sons are going to be healthy. So if we look at a large family showing X-linked dominant inheritance, actually it looks like autosomal dominant inheritance. You would have individuals across multiple generations, individuals of both genders being affected with that condition and transmitting that condition. But what is distinctive here is that you are not going to see any male to male transmission, because the male individual who's affected is not going to pass on his X chromosome to his sons. So just to reiterate then, X-linked dominant inheritance looks like autosomal dominant but does not have any male-to-male transmission. And here usually females are affected, but they have milder phenotype as compared to the males. And in fact, in certain X-linked dominant conditions, you may find only females in the family, or more predominant females in the family, because the condition could be lethal in the males. So one such classical condition is what we can see in this pedigree. So here you have these multiple females. All of them have presented with some skin lesions, which kind of progress through various stages, and they also have some hair and dental abnormality, and they have history of deaths of male children. So this lady also had one male intrauterine device, and here also we find a neonatal death of a male child. So here basically this is kind of this particular condition is basically something called as incontinentia pigmenti, and this is also an X-linked dominant disorder, but here the mutation is so severe that a male with this particular mutation is not able to survive. So here you have a male lethality. So all the affected males are going to usually die in the perinatal period. So you would have a pedigree whereby there would be female predominance, or only the female individuals are going to be affected. So some common X-linked dominant conditions besides hypophosphatemic rickets and incontinentia pigmenti are Rett syndrome, Aicardi syndrome, orofacial digital syndrome, and Melnick-Needle syndrome, and another metabolic condition also. So then between the spectrum of X-linked recessive and X-linked dominant, we also have some other unusual kind of inheritance patterns or mechanisms, or you can say phenomena, which are occurring in this kind of X-linked genes or X-linked conditions. So here we have a pedigree where there are two males who are both affected with severe intellectual disability, and they have some kind of subtle facial features also, little prominent chin, which you can see in this child, somewhat anteverted, and prominent ears are also there. And then these brothers have a sister who is also affected with mild intellectual disability. And then on further probing, we find that the mother has premature ovarian failure. So this is actually quite classical of a particular genetic condition called as Fragile X syndrome. So for this particular specific genetic test is done, which is called as TP-PCR. So because in this particular condition, we have the mutation in the form of a triplet repeat expansion. So there are certain stretches of these triplet repeats which are there in these which are there in normal individuals also, but when these stretches or the number of repeats crosses a particular threshold, then we have the disease manifestation. So here basically we have this particular repeat expansion in the FMR1 gene, and in the mother what we are seeing is that what we call as a pre-mutation. So the number of trinucleotide repeats less than 50 is a normal thing. So in the mother, we have one X chromosome having 50 repeats, but expansion beyond this, what is seen here on her other X chromosome, she has 80 repeats. So this is known as a pre-mutation. And number of repeats becoming more than 200 is what is called as a full mutation in this gene. So in fact, all the siblings, the males as well as the female, have had more than 200 repeats in the FMR1 gene, and this is located on the X chromosome. So both the males and the females were manifesting, although the females were manifesting the female was manifesting a milder phenotype compared to the males. So this is something which is called as a semi-dominant inheritance. So basically here, not all females are going to manifest. So around 50% females with the full mutations would also develop manifestations in the form of intellectual disability, but usually they would have a milder phenotype compared to the males in the family. And the phenotype of the female is actually determined by various mechanisms, in addition to the size of the repeat expansion. So various mechanisms like methylation, the mosaicism for the repeat in different body cells would actually determine the phenotype of the girl. So um, traditionally, we have classified the X-linked inheritance into the recessive conditions which are manifesting in males and not in females, to the dominant conditions which are manifesting both in males and females, to the semi-dominant ones which manifest in some of the females. So the examples of that is given here. So as we can see, so here in all the conditions, there is 100% penetrance in the males, but the severity index could be different. But if you look at penetrance in females, so for the X-linked dominant condition like hypophosphatemia, the penetrance in female is also 100%, and also she is also significantly affected. Whereas if we look at the X-linked recessive condition, there is very low penetrance in the females, and then they have, even if they manifest, it would be a very mild phenotype. Whereas if we look at the semi-dominant condition, which is Fragile X, 50% of the females are manifesting, and they have a quite moderately significant phenotypic manifestation. But then not all X-linked conditions would neatly fit into these three categories. So if we look here, this is a common metabolic condition, that is Fabry disease. So this manifests in all the males, of course, and also manifests in a significant proportion of females. But then the severity index or the degree of manifestations in females is quite low, and same is seen with even this particular metabolic condition. So how do we classify this? So this was one kind of a landmark paper which was published in AJMG in 2004, whereby the authors concluded that it's not always a kind of or it's not always possible to neatly classify the X-linked conditions into these different groups. And in fact, most X-linked conditions or traits are just X-linked and not really recessive or dominant. So there is a kind of a spectrum which is there. And this kind of spectrum, or basically what is the spectrum, is mainly seen in the female. So why do we have this kind of a varying female phenotype? So besides the impact of the variant, whether it is recessive or dominant, and whether a very important phenomena which determines the female phenotype is the X inactivation pattern. So as we saw in the initial slide, so we expect the X inactivation to be random. We would think that around 50% of cells would have one X chromosome active and the 50% would have the other copy active. But actually, even in the normal situation, this range of which chromosome is inactivated and which remains active, this ranges from around 20 to 80%. So there could be normal individuals whereby 20% of cells are having one copy of the X chromosome active and 80% are having the other X active. So it's not like a completely 50% demarcation there. But if this kind of imbalance, or whatever, the disproportionate X inactivation crosses this 20:80 ratio, then we consider it to be skewed. So which means that one of the X chromosome is preferentially inactivated and the other is remaining active. So just to show basically here, if we look at suppose we consider the blue cells to be one X chromosome and the yellow one to be other. So in case of random X inactivation, you would expect probably equal proportion of cells of having the two different X chromosome, whereas in skewed X, then one particular type, or the majority of cells would have one X chromosome active. So how does this really determine the phenotype? So suppose for an X-linked recessive condition, you have this skewed inactivation of the normal X chromosome. So if majority of cells are showing inactivation of the normal copy of the X chromosome, so then that individual will manifest that X-linked recessive condition. And similarly, for an X-linked dominant condition, which we would expect to manifest in a female, suppose that female has a skewed inactivation of the X chromosome with the mutation, so she would not manifest that condition or would have a milder degree of manifestation. So this degree of X inactivation is one of the major factor which determines the phenotype of the female. And this skewing of X inactivation can happen because of abnormality of the exist region. So the exist region is the one which determines the inactivation of the X chromosome. So if there are abnormality in that region, that can cause the skewing. Or there can be certain other mechanisms, like if somebody has an X autosome translocation. So in such a case, so here if we see a normal individual, so these are the two X. So in the cells, one is getting inactivated, the one showing is being shaded lightly. So in two different cells, one copy and the other copy is getting inactivated respectively. Whereas if this individual who has a balanced translocation between an autosome and one of the X chromosome, and let's suppose this red star here represents the mutation. So in such a case, what will happen, that the cell would try to preferentially keep this chromosome with the mutation active, because if this gets inactivated, then we also lose the function of the autosome, and losing the function of the autosome is often not really going to lead to it's not going to lead to a viable cell. So this is not tolerated by the body per se. So therefore, the cells would preferentially inactivate the normal X chromosome, and the one with the mutation would remain active. So this is one of the mechanism by which you could have skewed X inactivation, and then this lady could manifest an X-linked recessive disease. And there could be certain other situations like a lady with Turner syndrome who has just one X chromosome. So she would also manifest an X-linked recessive condition. Rarely you could have a female who is having a mutation on both her X chromosomes, and you could have some rarer conditions like androgen insensitivity syndrome, whereby the chromosome complement is actually 46XY. So again, you have only one X. So although the phenotype is female because of this condition, but she is going to manifest the X-linked recessive condition. So in fact, there are various mechanisms which go on to determine the phenotype of the lady. So besides the X inactivation, and whether this is skewed to the chromosome with the mutation or the chromosome without the mutation, the strength of the variant per se, is it a severe mutation or is it a milder mutation, and whether there's a translocation. So all these together determine the phenotype of the female. So here there is one particular interesting case actually. So this was a lady who had presented with a bleeding diathesis, and she did not have any platelet abnormalities, and even von Willebrand factor antigen and activity were both normal, and she did have low factor VIII levels. She had a normal karyotype. So here in this case, we were suspecting possibility of a skewed X inactivation in her. And in fact, on molecular testing, she was found to be heterozygous for a mutation in the factor VIII gene. So for looking for skewed X inactivation, we have to do a certain specific assay. So this is a particular assay which we have done in our lab. So here this is use of a restriction enzyme which is methylation specific. So what happens here is that first we are digesting the that particular region of the X chromosome using the this particular enzyme, and then we are getting these two peaks which is representing the two X chromosomes. And then after the digestion with the methylation sensitive enzyme, we would expect these peaks to be same for both the chromosomes if they are randomly inactivated. Whereas if there's a skewed inactivation, as can be seen here, so in such a case, there is loss of one of the chromosome which is different, which is basically methylated. So due to this digestion, the peaks from that chromosome are lost, and we are seeing peaks from only the remaining X chromosome. So the difference in the height of these two peaks indicates that there is a skewed X inactivation. So besides this restriction enzyme based assays, there are certain other assays also which can be used to study skewed X inactivation if you have a female manifesting an X-linked recessive condition. So to conclude, X-linked inheritance shows different manifestations in males and females because of the difference in the number of X chromosomes between them. And often if you have a large enough pedigree and multiple affected family members, you would be able to see a specific transmission pattern and easily recognize an X-linked inheritance pattern. Typically, a female is less severely affected than males for these conditions. The spectrum of female manifestations actually across different X-linked disorders reveal various interesting molecular mechanisms. And it is important once we diagnose an X-linked condition in a family to identify the carrier females in that family, because then these females, once they are identified, they can be offered various reproductive options, and we can prevent the recurrence of the extinct condition in the family. So with this, we come to an end of this presentation.